Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for December 9th, 2021. Today's CME activity code is 484250. We've got an interesting case today. I think we'll have some fun with it. It's a little different. The case has been de-identified as usual. We have no conflicts that we need to report. And this is being recorded. It'll be available on YouTube shortly. If anybody is in the audience that is not on our mailing list, just send us a text or an email or something. We'll get you on the mailing list and invite all your friends, etc. And I think let's get started. It's Dr. Gashi's case. He's going to read the protocol, Casey.
Yes. All right. So our patient is a 45-year-old Black female who was sent to nephrology for evaluation of elevated serum creatinine and nephrotic syndrome. She recalls being diagnosed with lupus 20 years ago after her second pregnancy when her son was delivered with a skin rash that was ultimately diagnosed as neonatal lupus. She had arthralgias, positive ANA, anti-double-stranded DNA, as well as an anti-Smith antibodies. She has been on a variety of different immunosuppressive medications, including Cytoxan, which caused her to have hemorrhagic cystitis. She had Benlysta, rituximab, hydroxychloroquine, for which she developed cataracts and stopped, and also varying doses of prednisone. Currently, she's taking 500 milligram twice daily of MMF with no steroids. Her course has been complicated by steroid-induced osteoporosis and bilateral hip avascular necrosis that requires surgery. She hasn't had that done yet, but she is going to have that done. She has also had a history of Staghorn calculi in both kidneys that required percutaneous nephrolithotomy. Review of her old records show that she had a creatinine of 1.8 and a urine protein creatinine ratio of 2.5 grams per gram about a year ago. Under current evaluation from rheumatology, her creatinine was up to 2.7, and now she has 10 grams per gram of proteinuria, which prompted her urgent referral to nephrology for a biopsy. The patient has a pretty poor history of follow-ups, and despite her rheumatologist's insistence, she'd never really seen a nephrologist, nor has she had a kidney biopsy in the past. Review system is significant for occasional flank pain on both sides, persistent hip pain, right greater than left, fatigue, and weight loss of about 50 pounds in the past year. She has no arthralgias, myalgia, skin rash, hair loss, alopecia, and so on. She denies any lower urinary tract symptoms like dysuria, gross hematuria, urgency, or incontinence. Her past medical and surgical history are significant for lupus, hypertension, migraines, osteoporosis, hip AVNs, Staghorn calculi. Social history: she never smoked, drank, or used illicit drugs. She's single and has 2 adult children. Her medications are amlodipine, lisinopril, metoprolol, Cellcept, as needed Tylenol, albuterol, Flexeril. She's on vitamin D and oxybutyrin. Her exam: she is normotensive, blood pressure is 107/64. The rest of her exam is significant for a BMI of 21. And as I mentioned, she used to weigh about 180 pounds. Now she's down to 134 pounds. She appears cachectic. She's very anxious. She does respond to all questions appropriately, but has very poor insight into her history or her disease. She often refers to her family members for answers. Her head and neck exam was unremarkable. Cardiopulmonary exam was unremarkable. Her abdomen is soft and non-tender. She does have severe pain with flexion and in basically the Faber maneuver, which is flexion, external rotation, and something else of the hip. But basically, it's a sign for avascular necrosis. She has no pitting edema. Her labs: sodium 142, potassium 4.1, chloride 115, bicarb 11, BUN 27, creatinine 2.7, glucose 84, total protein 7.4, albumin 1.9, calcium is 9.1, adjusted 10.8. Her LFTs are normal. Her white count is 5.9 with a differential that's listed. Hemoglobin is 8, hematocrit 27, platelet count is 533. She is microcytic with an MCV of 65 with low iron saturation of 9% and a ferritin of 133. Her ANA is positive at a very high titer. She has a slightly elevated anti-double-stranded DNA of 7. C3 is 114, C4 is 23. I have to mention her ANCA was negative. SPEP and UPEP did not show any monoclonal spikes. Her Hep B, Hep C, and HIV are all negative, as are her Quant Gold and COVID tests. Her urine shows light orange color, turbid, specific gravity of 1019, pH of 6.5, 4 plus protein, 2 plus blood, 500 leukesterase, greater than 180 WBCs, 40 red blood cells, many WBC clumps, moderate bacteria, and a urine culture that grew mixed flora and E. coli. Her random urine protein was 1286, urine creatinine of 134 with a ratio of 9.6 grams per gram. CT of her abdomen and pelvis shows multiple bilateral renal calculi. On the left, the largest was 1.5 centimeters. And on the left, it was about 0.5 centimeter. Bilateral perinephric fat stranding, large hypodense areas throughout the renal parenchyma on both sides, but no hydronephrosis or hydroureter. Her bladder was unremarkable. They also noted bilateral hip AVNs and hypodense splenic lesion. A percutaneous renal biopsy was performed.
Any questions for Dr. Gashty?
Casey, you probably said this and I may have missed it, but any NSAIDs with all of her pain issues and hip pain?
She's been on, yeah, she has a history of NSAID use. It's kind of on and off. Recently, since she's been seeing rheumatology, she has been essentially switching to T3s, Tylenol 3s, and not been using NSAIDs in the recent past.
So Dr. Gasti, Mario Rubin, do you have an albumin to creatinine ratio in the urine? The reason I'm asking is I suspect there is a superimposed urointerstitial problem here because she has a delta in the gap. And in other words, her anion gap is corrected for the hypoalbuminemia is 21 with the total CO2, which is much lower than predicted. And I'm trying to link that to the stones.
Yeah, Dr. Rubin, I completely follow what you're saying. We don't have an albumin creatinine ratio. This was essentially all done at rheumatology, and we admitted her for a biopsy because frankly, that this looked kind of like an RPGN and we wanted to get a biopsy as soon as possible. And so prior to the biopsy, I don't have an albumin to creatinine ratio.
Okay, thank you.
Another question, Casey, was from Dr. P. Was there any help maintenance that you had at that point in terms of her just age appropriate?
Yeah, she does. She has. Well, she's 45, so she's right on the cusp of needing a colonoscopy, but she has not had that done. Her mammogram she hasn't had done because she's really not very compliant with follow-ups. And Pap smear, I'm not really certain.
Great. Mr. Whittier, you want to walk us through your thoughts about this confusing case?
Yeah, sure. I'd like to say that a lot of this is a real case that we see a lot in practice, meaning we don't often get fresh lupus naive to treatment. So we frequently get patients who've had lupus for a long time. They've been treated with different varying medications over time, and then they've maybe had some variable amount of proteinuria or renal insufficiency over time, and then we're left guessing what it is when it's on therapy. And so that also makes it a lot more difficult because then you don't know if she would be serologically, active and the cell sept is keeping her relatively quiescent, or if she's always relatively serologically quiescent anyway. It just makes it that much more difficult, and it makes it that much more important to do the kidney biopsy. So anything that we say here obviously is going to be taken with a grain of salt because it's not a naive, or it's not a patient naive to steroids or to therapy. But, when I look at her case, I think, good Lord, I mean, she's had a creatinine of 1.8 from a while ago, and it's 2.5 now. So no matter what we see, we're going to see a lot of chronic damage. We're going to see a lot of, I think, chronic tubular interstitial disease, given that high creatinine. I think the tubular interstitial process is an important one here because we do, like Dr. Rubin said, have the non-gap acidosis. We've got a urine pH of 6.5. That sort of all points towards a tubular interstitial process. And I think there's going to be a lot of scarring there no matter what we see. But clearly with this much proteinuria, I also think there's a glomerular disease here. And it, you know, in the glomerular disease in the setting of lupus, when you're serologically a little bit more quiescent, of course it could be anything, but I kind of think of a podocytopathy. I may think of a lupus membranous. That's why I was asking a little bit about the NSAIDs, because we have tubular interstitial disease, and if there's nephrotic syndrome out of proportion to the serology, I would think about a podocytopathy or even a minimal change on top of whatever else is going on from NSAIDs. Her renal failure may also be out of proportion to whatever we find on the kidney biopsy as well, because she has the Staghorn calculi. She, you know, there's not an active obstruction right now, but it might not all be some interglomerular process. There may be some sort of component of obstruction as well. So if I have to guess what we're going to really see in the biopsy, I would say that there's going to be a glomerular lesion there, and I'm going to say it's going to be a lupus membranous, but again, it could be a podocytopathy. I'm going to say there's an absence of activity. I don't think that we're going to have segmental necrotizing lesions, and I don't think we're going to have a diffuse proliferative, excuse me. And I think there's going to be significant tubular interstitial disease, you know, probably almost in the range of 75% correlating to her creatinine, that's just really pretty high at 2.5, especially for someone who's so small. I mean, she's got a BMI 21 and a creatinine of 2.5, and longstanding lupus is going to be, it's going to be pretty bad what we see, I think. If it were a non-lupus lesion, you know, besides what I said there, it'd be hard to think about all that. She does have chronic inflammation, maybe a secondary amyloid. I can't really pinpoint anything except for lupus here.
Her serology isn't really that impressive, except, you know, I'd wonder if it even means that much, although she is a, you know, black female, younger black female, but her history obviously tells you she probably does have lupus, but the serology isn't really that impressive.
And you look at even the urine, it's hard to determine what the proteinuria is there, and that's obviously real, but you know, what do you make of the active sediment and the white cells? I mean, she has Staghorn calculi. Even her urine pH of 6.5 may not be reflective of a tubular interstitial process. It might just be protease, you know, with urease splitting organisms where you have an alkaline pH in the urine distal to the whole kidney. So there may not be even an RTA there, and that might just represent the alkaline urine from Proteus or some sort of urea splitting organism.
Yeah, it's a good point. You know, we classically think of Proteus, but there's a lot of bacteria that can do this. Dr. Glassick had some points in the chat room. I'd rather, in the chat box, I'd rather you just open up your mic and let us know your thoughts, Dick.
You know, AA amyloid is very, very uncommon in lupus nephritis, but it's hard to disregard this Staghorn calculi and the possibility of very long-standing urinary tract infections and chronic inflammation that might promote amyloidosis. You know, it's pretty outside the box, but I would just be thinking about problems related to chronic inflammation with this kind of Staghorn calculi.
Yeah, I think that's a great point. Let's put that aside just for the sake of discussion. And what are your thoughts about lupus in this case?
What are my thoughts about lupus?
Yeah, I mean, what if this is a lupus lesion? What would you predict?
Well, I would say membranous.
Okay.
Based on the normal complement and the absence of red cell CAS. The blood in the urine is hard to interpret with the Staghorn. I would certainly like to know whether or not the red cells were all isomorphic or whether there was evidence of acanthocyturia. But I think membranous would be the most likely.
Great. Anybody else have any strong opinions? Put it in the box, or if not, we'll move on, and we'll see what the biopsy shows. Get the wheel going here. All right. Oh, great wheel. Who shall read this biopsy? Awesome.
So Awesome said Nirali is controlling it. Give me a second, Nirali.
Awesome is one of our second-year fellows. This may be the last biopsy he reads since come January, we're going to have the first-year fellows start reading.
All right, Nirali, Nirali and Awesome, you'll be able to unmute.
Yeah, it might be the second last one. We have one more conference and it always picks me, but
Just remember there's a lag. So give me a second. I'm going to give you, let me share the screen and I'll give you control. All right, go ahead and click on the screen. All right, move the mouse. Yep, see if you can advance the slides. Just remember there's a lag. Okay. Good.
all right. So can you hear me now?
Yep.
Okay. All right. So we have a low power trichrome stain. We're looking at two cores here. Something that glares out is a lot of fibrosis and, the lot of tissues is scarred up. I would say probably 90% in both of these cores that we are looking at. I do see a glom here, which looks all scarred. Same goes here. And then again, in the lower core as well, we see there are at least 2 to 3 gloms which are completely scarred. So a lot of interstitial fibrosis, maybe around 90% or more than that.
Yeah, good. That's what I said. Extensive scarring, 90%. There's just a little island of healthy tubules up there at like 12 o'clock, like a cluster of 10 tubules, and all the rest is scarred.
Okay.
Are those, at this power, I'm sure it's hard to say, but are those red cell casts or are they just maybe a Highland type of cast?
Yeah, on the trichrome, both Highland and red cell cast stay the same. So we
Okay,
need,
so
H&E.
we'll wait for a higher power. Thanks.
Yeah.
Okay. Right, so we have a medium power, probably H&E stain. Again, the tubules are not back to back. There is a lot of fibrosis in between the tubules. I can barely see any gloms. Maybe there is one here right in the middle, which is again all scarred. Here in the tubules, again, as Dr. Sembelik mentioned, maybe it's like a hyalinization or a hyaline cast. I'm not sure.
Yeah, that's right. In fact, did you see what the comments are saying? What tissue in the neck region that this resembles?
Oh, it says like thyroid tissue, maybe
Yeah,
thyroidization.
yes, thyroidization. Yeah,
I see.
yeah,
Okay.
yeah. So the tubules get for this form of atrophy where they get uniformly dilated, filled with hyaline cast, and it resembles, colloid from a thyroid.
I see. Okay, yeah, but other than that, I don't see there is anything striking in this core.
Yeah, I agree. Extensive fibrosis, thyroidization, scarring.
Right.
Give it a second there. It's a little lag.
Okay. So again, we have a high power PAS stain. I do see there's a lot of fibrosis here as well. The tubules are kind of, spaced apart. Again, there is a lot of hyaline casts maybe, and same pattern as thyroidization. I do see 2 gloms here, one on the right side. This tuft is all shrunken with a lot of periglomerular fibrosis. And on this left side, there is another glom here. We do see a lot of fibrosis and scar tissue here, and apparently the glomerular capillary tuft is all shrunken probably.
Yeah. So 2 globally sclerosed glomeruli. In fact, in the entire biopsy, 12 of 14, 85% are globally sclerosed.
I see. And then here, it's again all fibrosis, right, Dr. Sembelik?
Yes. Yeah.
Okay.
That's all fibrosis.
Okay.
But so scar wasn't all there was in the biopsy. Here we are back to medium power. Over on the left, looks a little different than a typical area.
This part?
No, that's the right. Over there, yeah, at the left.
We need to teach our fellows the right and the left. I guess we left that out.
I mean, this part looks kind of abnormal too, so that's why I thought maybe it's kind of the other way. But Yeah, I'm not sure what to make out of it, but again, I don't really see much here.
Right,
I
right.
don't know
So we don't
what
see like
spots.
the tubular cast like before. We don't see glomeruli.
Uh-huh.
So we need to go higher power here and see what's there.
Okay.
Which will be our next slide. There we go.
All right. So probably the high power for the same area as you said. I do see some polys here, maybe like here, this one multi-lobe nuclei,
Mhm.
some lymphocytes as well in patchy areas. I'm not sure what are these white
The key cells, yeah, go up to 12 o'clock. The key cell are those larger cells with the foamy or bubbly cytoplasm. Those are foamy histiocytes. So when you get sheets of them like this, that's diagnostic of xanthogranulomatous pyelonephritis.
All right. Yeah. Sounds good. Anything else on this slide, or I think that's the major feature right here.
Yes, yeah, and in fact, yes. So now the next few slides will highlight. They'll become more obvious in the other slides.
Okay.
Yeah, again, so you have this inflammatory reaction, kind of destroying the cortex and medulla. Again, you see in the center of the screen, you have these larger cells with foamy cytoplasm, clear cytoplasm, some of them. Those are the foamy histiocytes. And then you have a sprinkling of acute and chronic inflammatory cells in the background. You have some polys, like you pointed out on the last slide. And then some clear plasma cells here. Just yeah, you see the dark nucleus with the off-center purplish cytoplasm. These are chronic inflammatory cells called plasma cells. And we have some lymphocytes scattered in there also.
Hey, David, is this, these foamy histiocytes, is that pathognomonic for XGP?
Yeah, I mean, when you have this type of widespread destruction like this, yes. Yeah, when they're prominent. Yeah.
I'm not sure what this is. Is this something?
That's probably just a capillary. I see some red cells in there and a couple of polys.
Okay, sounds good.
Yeah.
Clearly, what we don't see is tubules and glomeruli.
Right. Yeah. They've all been, run over, destroyed by this process.
Right. I think this is even more evident here, right? All these whitish areas maybe are again here I can see maybe this is another area of histiocyte.
Yeah.
Here.
Yeah, over at 1 to 2 o'clock at the edge of the biopsy, there's a whole sheet of them. Yeah, right there.
I see.
Yep.
Okay. Yeah, again, in this slide, I can't see any glom or tubules either.
David, how often have you seen something like this?
Very, very rare. I would say this is my probably second case in the last 10 years.
It's quite remarkable.
Yeah.
Well, I'm sure it comes through path occasionally in nephrectomy or mass removal, but from a standpoint of a renal pathologist doing a biopsy that we do, it must be highly unusual.
Yeah.
Right. Again, I think it's an H&E stain again, right?
Yes.
Like flower H&E stain. Yeah. Again, we can see the sheets of histiocytes here with patchy areas. Then we do see again a lot of lymphocytes, as well as some plasma cells and lymphocytes as well.
Yeah, and some clusters of neutrophils scattered throughout also. Yep. Yeah, so there was a small area of preserved renal cortex, so we could evaluate that now for any active lupus.
Yeah, so this is a high power PAS stain. Glom is right there. We have like the perivascular space. Then the tubules themselves look pretty open to me, the glomerular capillaries. there is, areas of mesangial expansion, more so in this area, and then it's patchy around this part as well. Maybe the GBMs are a little bit more thickened, but I would say the glomerular capillaries again look pretty patent to me. There is no evident crescent here that comes out in this glom. So some mesangial thickness with patchy, mesangial hypercellularity.
Yep. And then we have an arterial there, just to the, that's the hilum. If you keep going, if you go directly to the right, you'll see, they're right there. That's an arterial.
Yeah, that looks kind of hyalinized.
Actually, that's smooth muscle lining the wall of the arterial. And so the endothelium is right on it. So there's no hyalinosis. That look like shiny, waxy, glassy material.
Okay. See.
Yeah, so that's a normal arterial.
And this is proximal tubule, proximal condylar tubule.
Yep.
Okay. Is there any, I would say there is a loss of brush border here as well, or?
Okay, yeah, up around the top. Yeah, the brush border's a little lost in that one.
Okay.
That's one of the more normal things we've seen in this biopsy, though, because there is, you can see brush border at least half the tubule.
Mm-hmm. Again, there's the hyaline cast here in the tubule as well.
Yeah, so like I said, there was 2 preserved glomeruli out of 14. So here are the 2 preserved gloms that we're seeing.
All right, so this is a high-power H&E stain. Again, there's mesangial expansion that's pretty evident. The glomerular capillaries themselves seem to be pretty patent. Maybe some focal areas. I don't really see a lot of mesangial hypercellularity. Maybe in this area, I have more than 3 cells or so. But other than that, mesangial expansion is something more evident that we can see in cases of lupus nephritis. I don't see any crescent here as well. There is some periglomerular fibrosis as well in this slide too. The tubules themselves, again, there is, I don't know, we can comment on the brush border here. It's an H&E stain, but yeah, it's pretty much the same.
Yeah, those tubules in the top left look preserved, and then over on the right you see fibrosis and some tubular atrophy and hyaline casts.
Okay.
Yeah, so I did not see any lesions of active lupus in the 2 functioning glomeruli.
Yeah. And we have a high power trichrome, we have a high power Jones stain. Here we are looking for any split structures, spikes or holes. The GBM membrane seems to be pretty, smooth. I don't really see any of those features here. They're striking out. Maybe this area, there is some mesangial expansion here as well, I believe.
Yeah, this was one of the glomeruli that we saw that looked like it had mesangial expansion on the H&E that we saw.
Okay, got you. But again, glomerular capillaries themselves are pretty patent. There is no component of endocapillary proliferation that I can see here in this slide. No crescent, and the Bowman's space seems pretty open too.
Yep.
All right, so this is another high power PS stain. Is this a glom which is all scarred here?
No, because it has a lumen. Do you see the open space?
Yeah, might be.
That's an interlobular artery.
I see.
And it's showing severe, fibrointimal thickening and sclerosis.
All right. Yeah.
Yeah, so where the arrow is now, that's the tunica media, the smooth muscle, and so on. Just into that should be where the endothelium would lie, but you could see how significantly narrowed and sclerosed this vessel is due to all the chronic, changes in the kidney.
All right.
So on the tissue we'll go to the next slide. The tissue for the fluorescence was just scar and had no viable glomeruli. We had no sample for EM either, so all we had was a light microscopy.
All right.
So
you kind of mentioned, it's lupus, features of lupus nephritis that we can see in the form of mesangial expansion and mesangial cellularity, and as you mentioned, xanthogranulomatous pyelonephritis.
Great. Bill, how do you feel about this, not having IF and EM and not really necessarily having a diagnosis for a proteinuria?
Yeah, I mean, it's not ideal, but the real question I think would be, is it worth pursuing another biopsy to do that, or would it be, do we have enough information here to guide our treatment? And, you know, I think that knowing how significantly bad this biopsy looked, I mean, there's the infection there, which is one thing that I do want to mention, but just seeing how bad that biopsy was and knowing what her serum creatinine is as well, it made me think about this paper that I think, can you see my screen here?
Yes.
Hopefully. That the collaborative study group looked at just the baseline creatinine in patients, their long-term outcome with lupus. And, you know, what they found was not surprising, but even at a slightly, even above 1, you had a poor prognosis compared to less than 1. And this person's presenting us to us, you know, where these triangles are, and that's their long-term outcome just based on the baseline serum creatinine alone. And that includes survival, renal survival, and patient survival. So I think no matter what we have here, whether it is a membranous underlying for the proteinuria or if it is podocytopathy, there is so much tubular interstitial disease here that it's going to be really a bad prognosis. And there was just a lot of scarring. Now, the question really in my mind is less so about the proteinuria. It's really about, is any of this pyelonephritis and tubular interstitial disease reversible? We had such bad thyroidization, which would infer that it's not, but pyelonephritis is typically a reversible disease. And I know, though, that that's going to be really tricky because classic Staghorn calculi, you're always using antibiotics, you're always doing percutaneous procedures to try and reduce the nidus of infection. And so it's not going to be that easy of an infection to really treat, and certainly almost impossible to eradicate. In addition, having immunosuppression on board while you're trying to eradicate infections, not that easy either. So I think she's in a real tough situation here. What I would, obviously, it's going to have to be a multidisciplinary approach between infection and urology and rheumatology and us, but I would favor backing way off on immunosuppression, although she's not really on that much anyway. If I remember, Casey, she was on like 500 BID of CellCept. Yeah, so I mean, it didn't seem like there was anything active lupus nephritis that could really be treated there, and I would focus way more on trying and treat as much of the infection as we can, with, you know, focusing in more on antibiotic therapy and reducing CellCept. That's what I would try to do here. And even though we don't really have membranous or possibly podocytopathy, I'd have to assume that was there. But I think right now the more important thing to treat would be her infections.
Yeah, and I mean, you know, I'm glad you brought up that graph because it shows the terrible prognosis associated with lupus nephritis at presentation. On the other hand, I mean, I think this creatinine is not, I don't know that there's any evidence this creatinine is from lupus nephritis. This creatinine is probably from chronic XGP. I assume. I mean, we'll have to see what Dr. Gashty says about any further imaging, et cetera, but this is pretty bad. And I don't think you can eradicate these infections when you've got a chronic stone in there anyway. So even if you decided to immunocompromise her further, I think you might be asking for more trouble than it's worth. Now, I guess the possibility is a sampling error. Let's say that XGP, I believe, is usually unilateral, and maybe the other kidney doesn't look so bad. And maybe there is a reason. Maybe you take this kidney out and the other kidney's not involved, and then you get another look. Maybe you biopsy the other kidney and see if there's lupus nephritis. There's a lot of permutations here, a lot of possibilities of how to approach this, going ahead. As I remember with XGP, what Dr. Glassick brought up, the possibility of amyloid, is interesting because I think that chronic inflammation associated with this has been shown to be associated with AA amyloid. But we don't know. We don't have any of those stains. This might be a case where we could, the original pronase was developed for cases where you didn't have enough tissue or glomeruli on the IF, and it's possible we could send this back and get an IF. I don't know if they can also do a retrospective Congo red as well. I don't know if it matters, given the
I think
severity
David can do the immuno SAP stain if we were to ask for it at least. I mean, we have that available, right, David? We've seen that on other cases. serum amyloid
Right,
P
right. Well,
protein.
I did do a Congo red on the tissue here, and there's no evidence of amyloid.
Oh, you did.
Um,
Okay. So that was on the tissue you had, but we have no IF.
Right.
Okay, I stand corrected. Well, that's interesting. I mean, that's good to know. Okay. Dr. Rubin, what are your thoughts about this case?
There's not much more to add. I mean, what's puzzling to me is that she has no history of recurrent urinary tract infections. But I guess some of those cases are like that. But I really don't. I mean, I just think it's a fascinating case. I think regardless of what you do, she's looking at end-stage kidney disease, and this is the kind of case in which I will do a bilateral nephrectomy prior to transplantation.
Yeah, that's for sure.
Which is not usually done anymore.
Yeah.
But
no,
in
that's-
this case, no questions about it. Fascinating.
And that's based on bilateral staghorn. So the assumption is that you've got
Well, it's a
chronic
form
infection
of
both.
chronic urinary tract infection, and as was pointed out, you know, the minute you hit with immunosuppression, this thing will blossom, and you don't want that.
Yeah. So one of the possibilities would be to go back and rebiopsy just to get a better, get a better look of what the etiology of the proteinuria is. I guess so amyloid's out. The other thing I was thinking about was maybe a severe reduction in renal mass with secondary focal sclerosis. But if that's the case, you know, there's really no specific treatment for it anyway. And immunosuppressive therapy is pretty much out because of the chronic infection. So we're kind of between a rock and a hard place.
Yeah, the other thing is we don't know for sure what kind of proteinuria this is. I mean, could this be tubular? Yes, it could be. I mean, Dr. Glassek recently addressed the issue of nephrotic range proteinuria in tubular interstitial diseases. He gave the example of dense disease in the communities, but you know, I think we have seen from time to time a handful of cases of tubular interstitial disease with nephrotic range proteinuria. So I would like to get a UPEP and just see what kind of tracing we have, or the usual delta that you, Roger, point out on urine protein and urine albumin creatinine ratios and see.
Yeah. Well, let me hand it over to Dr. Gashty, because I think he has some follow-up and some ideas, having seen the patient himself. Casey?
Okay, so this was, we had the CAT scan before we did the kidney biopsy, and the CAT scan was pretty remarkable in a sense that both kidneys were involved, and they were pretty significantly involved. We, you know, couldn't, based on the CT, which I will show you. There's a video of the actual CT scan of the patient that you'll see. Both kidneys are pretty much involved from the upper pole all the way to the lower pole. So I don't know about a sampling error or a rebiopsy, because it just seems like she has significant bilateral disease, and that by itself is quite unusual. Pravir, can I go to the next slide? So some of the features that, while the slide loads, I think it kind of looks like it's slow to load, but some of the features on her presentation, the 50-pound weight loss that she has, a significant amount of anemia, these on and off flank pain, that history of having stones that required percutaneous nephrolithotomy about 4 or 5 years ago, with obvious residual stones that continued, have sort of led her kidney to look something like this on the inside. And this is sort of xanthogranulomatous, essentially refers to these yellow discoloration of pyelonephritis within the kidney. And as you can see, it just really replaces the healthy tissue of the kidney. And as a result, when you do imaging on CT scan, next slide, Pravir, it has this characteristic, you know, sort of bear paw effect, where you see the paws of a bear with highlights of yellow right around the areas of pyelo. And this particular CT is not the patient's, but this is unilateral, and you can kind of see a nidus of infection. So next slide. These are some of this is the actual video of the patient. So if you play the video, we're going to just go up and down the CT scan. You can kind of see both the left and the right kidneys have diffuse involvement. There's really no area of the kidney that is preserved. So we had urology see the patient, and I'll kind of give you guys a little bit of an update. Usually the treatment of these is surgical. It's basically either a partial nephrectomy with an affected area, or if it's diffuse involvement, it's just total nephrectomy. But since she has bilateral disease, the dilemma with this patient is you have to do bilateral native nephrectomies. That probably will help her get over the infection, and maybe that weight loss that she's having in the cachexia will reverse, but then we're going to have to basically put her on dialysis. So I think that's one of the harder points of this case, is to convince both myself and the patient to basically have both of her kidneys taken out and get on dialysis with the hope of at some point getting a kidney transplant. That's one option. The other option would be to essentially put her on antibiotics, initially maybe higher dose than chronic suppressive therapy, and just basically watch and kind of see if she can maintain her level of creatinine at 2.5 to 2.7, and just kind of watch her. So next slide. So here are some things that are highlights of xanthogranulomatoous pyelonephritis. It's a very unusual variant of pyelonephritis. In fact, if you look at all the nephrectomies that are done for chronic pyelonephritis, about 20 to 25% of them are XGP. So it's not uncommon, but chronic pyelo with nephrectomy by itself is quite uncommon. It's usually associated with obstruction and infected stones. So this patient had Staghorn calculi. She's had, her urine has sort of been active with leukoesterase and positive urine culture. So it's not surprising that she has had this for a while. The bear paw sign on CT is something that I showed. This could be confused with malignancy. Malignancy, especially if it's unilateral and it involves one part of the kidney, this could be confused with renal cell carcinoma. So the recommendation is to do a fine needle aspiration for histology to confirm the diagnosis. Malachoplacia, which is essentially the same thing, it's this chronic inflammatory process that replaces healthy tissue, is very similar to XGP with two main differences. One is that Malachoplacia really involves the bladder for the most part, the lower GU system. Only 15% involves the kidney, whereas XGP is essentially pyelonephritis, so it involves the kidney. So that's one difference. The other difference is there are characteristic cells which are called Michaelis-Guttman cells, which are PAS positive on Malachoplacia, whereas usually in XGP, it's a PAS negative type of process. As I mentioned, this is one of the main features of this, is it's always unilateral. There are only 7 cases in the entire literature of bilateral XGP. And in those cases, obviously the patient is either on suppressive antibiotics, or they do partial nephrectomy and they take out areas of disease. But in this case, I think there's such a advanced degree of kidney disease that it's unlikely for that to be effective. The urine culture usually gives you one of these urea splitting organism, E. coli, Proteus, Pseudomonas, or Enterococcus, but 25% could be culture negative. So in a chronic setting, as mentioned, the chronic inflammatory process could lead to secondary amyloidosis. Our patient did have a Congo red stain that was negative, so that's at least not a concern. And as I mentioned, definitive management being surgical. So again, I posed the question back to the group, is the two options are, so what we did was, I called ID, I called urology. Urology said, we're not touching her. She's too ill and she's got this active infection, and it basically is a diffuse involvement of both kidneys. Her GFR is quite low because she has such a low muscle mass. So a creatinine of 2.7 is really a very low GFR for her. And unless you're ready to put her on dialysis, we're not gonna do any kind of a surgical intervention. Infectious disease basically said put her on about 8 weeks of Augmentin based on the sensitivities that came from her E. coli, and then we'll reassess. So as of the last follow-up, which was a couple weeks ago, her creatinine is about 2.4. She feels about the same. She's still on Augmentin. I did talk to her about the possibility of having to essentially remove her kidneys and putting her on dialysis and transplant lists. And she's not really a big fan of that. And I'm, to be honest, very conflicted on this anyway myself. I'm not really like sure which one is worse, putting somebody on dialysis with the possibility of maybe never getting a transplant. But if this goes untreated, sometimes the infection can actually spill over to the outside of the kidney. It could actually invade the surrounding tissue, create fistulas to the bowel, to the spleen, and that would obviously be worse. So, you know, this is not an easy management case. So I'm happy to hear everybody else's input, but that's kind of where we are. She's creatinine of 2.4 on Augmentin, talks about nephrectomy, but nobody's really happy or comfortable about doing it, and that's where we are.
So really nice discussion of something we don't really see a lot of. You know, if you look at the comments in the chat box, there's a strong feeling that this is this is much worse than it appears on surface. She's lost 50 pounds. I mean, you know, I'm going to be a little histrionic here, but I think she's dying from this chronic infection. It's like a foreign body, you know, there's chronic almost pus in her belly. And I would argue that this may be the toughest decision you make, to take somebody's kidneys out. But, you know, as Dr. Glassick said, this could be life-saving. I mean, this could be a terminal condition. And will she die of this? No, she'll die of, you know, malnutrition and sepsis and weight, you know how that works. But, and you'd hate to take them out and then she doesn't gain weight. But I suspect that may be the problem here. But again, to do that it's going to take a lot of effort. I don't think antibiotics will ever clear this. But I'd like to see anybody else's opinion on this. Dick, you want to speak up? Dick, you're muted.
I mean, I agree with you.
Am I
Walter.
unmuted now?
Go ahead.
Yeah, you're good.
Yeah, Roger, I agree with you. I think this patient is on a death spiral. And I don't think that antibiotics are going to cure this widespread xanthogranulomatous pyelonephritis. And I think the only way to save her life is to take out her kidneys.
Have either you or Mario, you guys have seen a lot of medicine in your day. Have you ever seen a case like this of bilateral where you're actually doing this to say, you know, it kind of reminds me of von Hippel-Lindau syndrome, where, you know, you have to remove the kidneys, put them on dialysis to save their life and also make them a transplant candidate. Have you ever seen anything like this with the XGP?
Not me.
No.
Suki's in the audience too. He may want to comment on that.
Okay, Dr. Suki, have you seen anything like this? Well, Casey, have you had discussion with her about the, you know, the severe possibility?
Yeah, we did. I mean, that's really that's what the literature suggests is, you know, take the kidney out. This is a surgical management, period. Although most of the literature that comments on that is always commenting on unilateral. So nobody's putting them on dialysis. They're taking one kidney out and the patient continues to be off dialysis. She is quite cachectic, which, you know, you can say that's reversible from chronic infection. She's got bilateral AVNs. She's in constant pain. She just looks very miserable and cachectic. And I'm not sure how immediate she's going to be a transplant candidate, even if you do a bilateral nephrectomy. So, you know, what I struggle with is, okay, so we take these out, put her on dialysis. She gains a little bit of weight. She gets her hips replaced. Then she can get a kidney transplant. And to sell her all of that, which I have been trying to, is a little difficult. She's just not seeing that far down the road. And dialysis is not one of those easy concepts for people to accept. They go, I'm taking your kidneys out. Whereas she's like, well, I'm urinating. I'm not in much discomfort. I'd rather take the antibiotic. And the weight loss is, you know, as much as I would tell her that she would continue to deteriorate, she doesn't feel bad enough to say, I would rather be on dialysis than do this. So
sorry, I was
bad job selling this, but Dr. Suki.
I'm sorry, I was muted, couldn't get unmuted. in answer to one question, I have seen XGM, but not bilateral. But my sense of this case is the same as has been articulated already. She has bilateral infected kidneys. She's lost 50 pounds. She's, I'm sure, sarcopenic. Now that creatinine does not at all represent her renal function. She is in much worse renal function than that serum creatinine would lead you to believe. And I think she's frail. And as Dick Glassick mentioned, I think she's on her way to die unless something heroic is done, such as bilateral nephrectomy, try to nourish her, rehabilitate her, and then hopefully get her a kidney.
I like that word heroic. I mean, it's because she doesn't feel it, and I mean that'd be a lot for her to go through. But you know, she's she's malnourished, she's anemic, she's her CRP is probably and sed rate is off the wall, and maybe it may be tough to convince her. And like I said, it must maybe the toughest sell you have, but it might be one of the more rewarding cases of your career too, because I think the consensus here is she is dying from these masses. And I don't know. I mean,
like Dr. Reen said in the chat, he had a case where he was mentioning that he said they thought was cancer and ended up being SGP. But this is basically acting just like cancer. It is exactly like cancer. It needs to be like your von Hippel-Lindau's, like you were saying, Roger. I mean, it's cancer that needs to come out. It's causing all these issues with her, and those issues I don't think are going to ever get better.
So I think you have your hands full, but ultimately it's her decision and with your persuasion. But I think that's a consensus here. It's ironic that we've gone through all this without a glomerular diagnosis, but it becomes moot. And I think it's as much a discussion as we've had about anything, and as important discussions we've had about anything in a long time.
Well, the nephrectomy will treat her proteinuria as well.
it will treat her I think it'll treat a lot of things. They'll treat her anemia.
She can have NSAIDs again.
She has no living donors, I trust.
No, she's really very poor insight, very poor follow-up. There's just a lot of concerns about her overall health. But I don't disagree, which means I agree with everybody's consensus that she needs to have nephrectomy. Urology is very hesitant to even touch her. Just look at her and they say, she's too frail and creatinine is 2.5. They obviously don't understand the concept of low muscle mass and the creatinine and GFR correlation. But it's been a really tough sell for her. So I'm going to continue to try to do that. But I'm on board with bilateral nephrectomy being the final conclusion in this.
It's a very sad case. This poor woman. I mean, she's got aseptic necrosis. That is a big deal in itself, and
that's why she went to rheumatology, because ortho said go see rheumatology before we do anything. So they image her hips. She's got AVN from all the steroids she's been on, and then rheumatology says, oh, you have lupus. Let's do a workup. Creatinine's up. Let's send her. I mean, this all kind of came about because she suffers from hip pain. So at some point, I think what the patient presents with also matters. Because she's basically saying, just get rid of my hip pain, and I don't need anything else.
Yeah. Well, great. I'm going to wrap this up. Great case, a lot of fun. I mean, welcome to urology conference today. Appreciate everybody coming, and thanks, Casey. That was a great discussion. It's an odd case to be biopsying and making that diagnosis, but I think in the end, you may do as much for her, have the potential to do as much as for her, or much more than if she had lupus anyway. So, great job. Today's CME activity code is 484250. Thanks everybody for coming. This will be posted in YouTube shortly. Keep your eye open for emails as far as our weekly conferences. We should be back next week, but follow our email. And until next conference, everybody stay safe.